Good evening, everybody. Welcome to the GW Rodham Institute's Impact Speaker Series. Today is, February the 23rd, 2021, and this is part of Heart Health Month. It's also Black History Month. And my name is Gigi. I'm the founding director, and I'm just delighted that you're joining us this evening. We've been very busy, and Ms. Carter has put up the slides for tonight. We've got some incredible guests. My friend and colleague, Dr. Jannet Lewis, who's professor of medicine in the division of cardiology, and she's also the director of GW Women's Heart Center. And my other colleague, Ms. Jennifer Leon, who is a registered dietitian. She does the nutrition for cancer patients in the cancer center, but also she's a clinical instructor at the medical school. And today we're going to find out more about both of these colleagues' work, but also how heart disease specifically impacts women, and then maybe even some discussion about COVID and the effects on the heart. But first, I'd like to tell you a little bit about the Rodham Institute. We have a wonderful series that we have. We're co-sponsoring with the Children's National Medical Center and the Black Coalition Against COVID. We're actually, the Rodham Institute is on the steering committee of Black Coalition Against COVID, and it's for young people, called COVID-19 and Beyond series. If you haven't heard, unfortunately, among youth, the suicide and depression rates have really escalated. I hope that you will be able to join us tomorrow from 12 to 1. Next. We have an information session tomorrow evening. This is for our health education leadership program for middle and high school kids. Please go to our events page to learn more. Everything is free that we do. Next. And finally, please visit our website to learn about our priorities. We feel that all of these issues of health equity, legal justice, social justice, and economic justice are really interlinked, and they really have to be addressed simultaneously and in parallel. Finally, these are our 3 priority areas: the youth and programming workforce, training our current and future health professionals in applied health equity, and community collaborations. And this is our website and has a lot of resources about COVID, including food and mental health. And then last but not least, our incredible staff. We all work together and they just are so hardworking. Ms. Tracy Bass, Ms. Christina Williams, and Ms. Ashanti Carter. Here are the social media handles, I guess they say, and our website, email. And so I'm going to just welcome our panelists, again, Dr. Lewis and Ms. Leon. And welcome. I'm so glad that you could join us. So I guess we'll start off with you, Dr. Lewis, and, please educate us about heart disease in women. We hear so many things about, women present differently, women may not have the same symptoms. Can you give us an idea about how heart disease manifests in women?
Sure. So the first thing I'll lead with, which is still surprisingly not universally recognized, is that the leading cause of death in women in the United States is cardiovascular disease. As often as on a daily basis, when we try to ask these women, when we do surveys and ask women, what do you think is the most common cause of death? The fear, of course, is cancer, which we're all very fearful of. But over your lifetime, the most likely thing to cause a problem is going to be cardiovascular disease. There's a lot of stuff in the literature. There's a lot of stuff online, some of it accurate, some of it not so accurate. When we talk about cardiovascular disease, we're talking about a broad spectrum of things, and we can discuss that as the session goes on. But in the African American community in particular, probably the most common cardiovascular disease is hypertension. In this country, there are over 1 million people, 100 million people with hypertension. The overall prevalence is, less than 50%, so 47%. But in Blacks, in African American, that number is more like 60%. I have an 86-year-old father who's in really good health. And when I give these lectures or when I talk to him, I said, Dad, you're the only Black guy I know who doesn't have hypertension. So that's the most pervasive problem. And it's not as sexy as things as putting in devices, but I see a lot of, and I know you do as well, see a lot of patients with hypertension. The other cardiovascular diseases, of course, that come to mind are heart attacks, so coronary artery disease, valvular heart disease, and we'll get into this a little bit later, but heart failure, especially as it relates to COVID-19. And I'll stop there.
Okay. Well, I was seeing a patient today in clinic just before we started the webinar, and her blood pressure was very high, 190 over, I want to say 95. And she says, but I feel perfectly fine. And I said, well, that's why it's called the silent killer. And I think a lot of people don't make the connection between high blood pressure. I think people understand the connection with the heart and the kidneys, but I don't think that people realize that one of the entities, one type of dementia, is what we call vascular dementia or multi-infarct dementia. So basically, people can have these small silent strokes that pick off the brain and cause you to, lose your memory, and they're indistinguishable from Alzheimer's disease. And that can actually, that's a preventable type of dementia. And so you're right, there's a lot of mythology out there. So, you alluded to this, but what would be the best site to visit if a person has a computer and internet to read about heart disease, or if they've got any questions?
The AHA, the American Heart Association, has a great website for non-medical people. And it's reliable data. The AHA doesn't do its own research, but it funds a lot of research. Mm-hmm. So there are a lot of websites that are not so reliable. And I'm sure you also get people who come in to bring you literature from the web. But that's a good website. WebMD is okay. Some of the academic sites, like Mayo, has a great website. Yep. But I think the American Heart Association would be a good place to start.
And blackdoctor.org, actually, it's got over 20 million followers. They actually have more followers than MD. And I always use as a guideline, if the URL has gov or org, that tends to be a bit more objective than com, which is commercial, right? So blackdoctor.org or cdc.gov, it tends to be a little bit more objective. So Ms. Jennifer, Ms. Leon, welcome. And can you tell us a little bit about yourself? I mean, I think most people know what doctors do, but what is a registered dietitian?
Thank you. Thank you for having me. I'm excited to be here. A registered dietitian is a person who's gotten a lot of nutrition education, either at the undergraduate level or at the graduate level, and then they went through a lot of training in medical facilities and then took a national exam. In this area, we're also licensed in Maryland and in DC. Virginia does not have licensure, but so it's a licensed health professional. The people that you would see at a cancer center or in a medical school or at a hospital would be registered dietitians or dietitians, but it's okay for people to call me a dietitian or a nutritionist. It's okay.
And so, oftentimes when I see patients in the clinic, people perceive their health in different ways. And part of this is cultural, part of it is how you grew up, all kinds of things. My father, who is 86, Dr. Lewis, and does have hypertension, whenever he has a high blood pressure reading, he's like, I'm hypertense. You're getting on my nerves. That's why my blood pressure is elevated. And I think in a lot of cultures, there is the association between mood, certainly food, and as well as health outcomes. And actually, in point of fact, he's right, when we talk about the structural and the social determinants of health. And certainly in the clinics, and I know all of us have seen this with the triple pandemic of COVID, the serial murders of Black people, Trump, all of that, the amount of stress and mental health issues, even quality of food that we're eating, people are gaining the COVID-19, all of these things factor into that. So Dr. Lewis, I mean, is my father right by saying we're making him tense and that's why his blood pressure is going up?
Well, I can't speak to the part about you making him tense.
It's not me. Wait. I'm the oldest. It's not me. It's not me.
Very clearly, stress raises the blood pressure. Now, sometimes it's only transient, but when we're in a stressful situation, our blood pressure will rise. So think about being in a chronically stressful situation. Now, I'm not implying that the only reason for high blood pressure is stress and tension, but it absolutely contributes to it. And when I counsel people on taking their medications, I try to get them to also change the way they approach stress, because everybody has stress, right? You cannot live in this world, and certainly in this country, without stress. It's how you approach the stress and the things that you do to manage it and how your body reacts to that stress. But there's a lot of low level, for the reasons that you just enumerated, a low level stress among a lot of people.
Mm-hmm. So here's a question already from one of the on chat. Is that why every time I come to GW to see either of you and can't find my a parking space, that my blood pressure is up?
I have a feeling I know who that is, so I'm not going to call any names. But you do know, if you come to see me, and probably Dr. El-Bayoumi as well, that when your blood pressure is up, I say, let's sit for a while, and I'll sometimes turn, depending on how high, turn the lights out and have you lie down for a few minutes and come back and take it. So I rarely act on that first pressure when you run into the office and our wonderful but stressed MAs are bringing you in and getting everything done. But for a lot of people, their blood pressure is up just crossing the DC line.
Mm-hmm. Yep. So Ms. Leon, I mean, you know, a lot of patients, first of all, we as physicians in general, this is changing, but I don't know if we even had a course more than a lecture. I think we just got a lecture on nutrition when I was in medical school. And so we are certainly understanding that food is essential for our health and well-being, but also can play a negative role. So can you talk to us more about the sort of the basics of nutrition and what we should know, because it's sometimes so complicated, and talk about mythology. We hear a lot of contradicting information.
Yeah, that there is so much information out there, and there's so many guidelines, and depending on, you know, what your history is and what your family history is, you may be getting different information from different sources. So it can be confusing. And the best way that I could describe general recommendations, we'll sort of focus on the topics we're talking about today. So we'll focus on heart health and cancer risk reduction, which they share most of the same recommendations. So it's easy to talk about them both. And the general idea is to try as much as possible within your culture, within your lifestyle, within your ability to purchase these things, and keeping all of that in mind, to try to have a general diet that has a lot of vegetables, some fruit, some whole grains, lean, healthy protein, whether it be vegetarian sources or animal sources. We want to try to aim to have, you know, depending on the source that you're looking at, but a way to think it through is maybe about half your plate could be low calorie vegetables cooked in a healthy way, either raw or sauteed or roasted. And then about a quarter of your plate would be a healthy protein, maybe fish twice a week, or chicken, or turkey. There's even some room occasionally for some red meat, or vegetarian sources are really wonderful. And then about a quarter of your plate would be the whole grain, hopefully, as much as possible, right? Nobody's plate looks like that all the time. But if that's your goal and you're thinking, my plate doesn't look like this, I don't even know where to start, the easiest way to start is pick one thing. What is one thing that you could change to make it look a little bit more like what I just described? And that's a general way of approaching it. The way a dietitian does this is we have all this general information in our minds, and we have that as resources. And then we talk to the patient and find out their ability to obtain food, their ability to cook it, their knowledge of it, their lifestyle, their stress, their prior medical history, their other conditions, everything together, and develop an individual recommendation, which is a little more, cognizant of everything that's going on.
Mm-hmm. And, I mean, I think that a lot of people, myself included, are sort of self-soothing with food. But here's a question for you, Dr. Lewis, because I hear this all the time. Well, but alcohol, red wine is healthy for my heart. First of all, especially since both of you are on, what is okay for your heart, but what's the limit so that you don't increase your cancer risk? So Dr. Lewis?
So it is a little different for men and women. So for women, you really shouldn't have more than a drink a day. And you can't save them all up. That's called binge drinking. And for men, it's more like 2 drinks a day. And beyond that, you start getting the downside of alcohol consumption. Now, for patients that don't drink, I don't ever encourage people to start drinking, because I've been asked that as well. I mean, there are a lot of data that suggests that teetotalers have a higher cardiac mortality than people who drink a little bit. But that's a very complicated data. But in general, if you're going to drink, for a woman, 1 drink a day, for a man, up to 2. And so, also be aware, and maybe our dietitian can help us clarify what a drink consists of.
We can do that. I answer that question a lot. Right. The healthy pour may not qualify as 1 drink. So it is a 12-ounce volume of beer, a 1.5-ounce volume of a spirit, or a 5-ounce pour of wine. And the best way to know what that is, honestly, is to take a measuring cup, pour 5 ounces into that measuring cup, and then pour that into the glass that you use when you make yourself a glass of wine, and sort of eyeball that. And then you don't have to do that again. Then you know what a 5-ounce pour looks like.
I would say a couple of things too. I always tell people, a shot of whatever whiskey is the same as a glass of wine, is the same as a, can of beer. But there are a couple of caveats to that. First of all, now the containers for wine, are like goblets, like we see in the movie. And so one thing that helps, whether you're trying to lose weight or trying to manage alcohol, is to get smaller containers to put your food in, right? Because that, of course, this better than I, that psychologically plays in. And then you, Dr. Lewis, mentioned the binge drinking. I don't think a lot of people are aware that alcohol is actually directly toxic to the heart. And actually, when we used to work at the VA, there's this phenomenon called holiday heart, because people will, let's say, watch, the football game or whatever else, and then drink a lot, and it basically throws their heart into an abnormal rhythm. So can you talk a bit more about the heart and alcohol, any type of alcohol?
Yeah, so I'm happy you brought up that, alcohol is alcohol, because a lot of people think that if I'm drinking beer, sometimes a lot of it, it's not the same as other alcohol. It's all alcohol, right? I mean, the volumes are different. But with regard to the heart, I guess there are a couple of things. One is what you were just talking about, and this is somebody who's healthy and has the binge excess drinking. And we see those people that come through the emergency room with an abnormal rhythm called atrial fibrillation, which can be quite dangerous. The other thing, however, that we see all too often are the chronic effects of alcohol on the heart and patients presenting with heart failure. And when I talk to some of the younger patients, it's interesting to me, interesting in a bad way. You have young people who've been drinking since they were teenagers, you know, getting into the liquor cabinets, and they've been drinking since they were teenagers and are presenting at 30-ish with really severe heart failure. Now we have a lot of things we can do, but as you know, we share this. I think everybody on this panel shares this. It's a lot better to prevent a problem. Yes, we have lots of wonderful interventions for all kinds of cardiac issues, but it is much, much better to prevent the problem in the first place.
Sure. So, you know, Ms. Leon, when you are counseling women versus men in terms of their nutrition, are there any differences?
There aren't differences that I recommend for women versus men for most things. So in general, if they're trying to reduce their risk for recurrence for cancer or trying to lose weight, the general recommendations are the same. If they have a specific health-related issue, for example, if there's a prostate cancer survivor, there are some specific recommendations related to that. But in general, especially with heart health, the risk factor numbers may look a little different, but the way to reduce risk is the same nutritionally for men and women.
It may just be different caloric intake because of the size of somebody or the age or any of these other factors.
Exactly.
No, I was just going to ask also, Dr. Lewis, I mean, are there differences physically? I mean, I think heart valves are the same in men and women, but are the blood vessels the same in men and women in terms of what feeds the heart and then the heart?
Yeah, that's a really good question, because what we've learned, you know, for a long time, we treated women like they were small men, and we had just assumed that the disease was the same except in a smaller person, or we thought that certain types of cardiac disease didn't affect women. So we learned a lot about that. That is not correct. There are some differences. The blood vessels, the coronary arteries, the blood vessels that feed the heart are smaller in women. When you look at the underlying way that people have heart attacks and you get down to looking inside those blood vessels, it does seem to be a bit different between men and women, but the overall anatomy is the same. Some of the physiology is obviously very different because of hormones or lack thereof.
So, you know, do women present differently than men if they're having a heart attack?
So there was a lot of press about the different presentation in women. My experience, and I think that most of the literature bears this out, is that most people, men or women, who have heart attacks have some kind of chest discomfort. Now, what women do have is they have other symptoms that might make them ignore that chest discomfort. So they may have more nausea, they may have more fatigue, but they usually do have the chest discomfort. Now, do some women present with no chest discomfort? Yeah, as do some men. But I think the bigger issue is that, I'll put it like this. So our offices are right down the street from the Hill, right? So if there is a guy sitting at his desk and he has chest discomfort and it doesn't go away in a few minutes, he is in the ambulance and coming to the hospital. What happens far too often with women, they have a little something in the chest and they go, must be something I ate. I have to pick up the kids. What are we fixing for dinner? And just this whole litany of things and reasons why you don't need to act immediately. So it's not so much that the symptoms are different, it's the reaction to those symptoms. And so I think that's really important for women to recognize. And I'll just say one other thing, because I've had this happen much too often. I've had women tell me, well, I didn't go because I didn't want to be embarrassed with them telling me it's nothing. So what? You know, it's an ER visit, and ER is not the nicest place to be for anyone, particularly now. But the repercussions of not recognizing a cardiac event are quite large.
But also, you know, she or her family may be advocating and doing all the right things, but sometimes it's on our end because of biases and taking care of women or people of color or disabled, et cetera, in which somebody say, no, they're there, dear. And that's certainly of taking care of patients where they've come in with symptoms and then the person evaluating them, the physician, says, oh, nothing to worry about, and they're actually having a heart attack. So I think you're right. There's more self-censorship among women, right? We tend to be last on our own list because of all the competing priorities. Can you speak a little bit more about sort of older people in general, men and women? Do they present differently?
So the average age for a heart attack in a man is about 65 years old. And the average age for a first heart attack in a woman is about 72, which is why the mortality tends to be higher. They're older and have other things. So in general, the presentation is pretty similar. Like I said, one of the issues with older women is that they have other problems going on. And so whereas a 50, 60-year-old man may come in and is having a heart attack, that is his major issue. For an older woman, she has hypertension and diabetes, both of which may be suboptimally controlled. So those things influence, you know, the overall outcome.
So, Ms. Leon, I know that you're involved in actually educating the next generation of physicians in what's called culinary medicine or food as medicine. How is that different? What is unique about that particular program? Would you like to share with us?
Oh, I'd love to. So culinary medicine is a program that was developed at Tulane and has been brought to UW. So the people who developed it at Tulane have been brought to UW. So now it's housed here. And what happens is that we teach medical students about nutrition and cooking. And so now in the COVID era, they are cooking in their own kitchens and experiencing what it's like to try and put together a healthy meal, right? Given all the stressors of being a medical student, which may look like, you know, not having a lot of time, not having a lot of space, not having a lot of money and all of that. And they're learning what it's like to cook the healthy foods that are recommended for different disease states. So we're sort of explaining these are the foods that are recommended for helping reduce risk for heart disease, for cancer, for kidney disease, and so on. But one of the exciting things about this program is that they're also expanding it to the community. And so there are community programs offered right now for free for people who want to learn just like the medical students are. And so they learn about healthy cooking, and they learn skills and recipes and ways to apply this knowledge in a way that's real and practical using healthy, lower cost, easily accessible items that fit with the overall model that I was describing. It's really exciting.
It is. And I should also point out that sometimes the reality of what our patients go through and what we recommend is really a big disconnect. So in Ward 8, which has about 80,000 people, there's only one Giant. And so, or, you know, sidewalks may not be safe to walk. And so I think that coupling that knowledge with really understanding where our patients come from so that we're not making recommendations that don't make sense or that could be frustrating to people because, you know, physicians especially have a way of making people feel guilty if they don't do what we suggest. And people really do. It's like your teacher, you know, you want to please them, or your parents, you know, or whatever. And so part of it too is that people don't come to the doctor if they feel like they're being scolded too often. So I'm so glad to hear that, you know, trainees are getting to see firsthand how challenging some of these issues are. So thank you for sharing that. So Dr. Lewis, I know that the way that I explain this to my patients is that there are basically 4 elements to the heart. There is the electrical system, there is the muscular system, there are the blood vessels that supply the main muscle, or the muscle in general, and then there are the valves. You know, I asked about, are there differences between men and women, and you mentioned them, but I know that there are some specific conditions that women have after pregnancy, or even, you know, after pregnancy or after child delivery specifically. Can you talk about those?
So I'm happy you brought that up, because one of the things that I've been involved with lately is I call it, my shorthand is cardio obstetrics. You know that we have a very excellent OBGYN program at GW, and I get quite a few referrals, both for women with underlying heart disease, as well as older women, for example, who are involved in the IVF program. But one of the things that has not been recognized is that if a young woman, a 29-year-old, has a hypertensive episode during her pregnancy, preeclampsia, or just hypertension, that woman has an increased risk of having cardiovascular issues in the ensuing years. And most of us get our primary care from our OBGYN doctors. So frequently, they don't necessarily get all of the primary prevention that they should be getting. So that's one issue. The other issue is that there are cardiac problems that are unique to women. So there is an entity that has a really long name, so I won't get into that, but the shorthand is broken heart syndrome. And we have women,
I think I've had that before. I shouldn't be joking, because it's a real thing, right?
It's a real thing. It's called stress-induced cardiomyopathy. So I told you it was a long name. But at any rate, it's seen not exclusively, but definitely the vast majority of women are postmenopausal. They've had some traumatic event, and they present with severe, sometimes life-threatening heart failure. Now, the good news is with appropriate treatment, most of them recover. So that's one of the unique things that you see for women, is this stress-induced cardiomyopathy. And there are also cardiomyopathies that are associated with pregnancy. And I'm sure you have some of those in your practice. I do too. And it's a very tough thing, because you're usually dealing with young women. And the risk, even if they completely recover, the risk of developing heart failure again with subsequent pregnancies is not inconsequential.
So there was a question that came through on the Q&A about culturally appropriate, or foods or recommendations that are really related and that can incorporate the tastes that we have. I don't even have to say culturally, because as individuals, there are some things that we like and we don't like. I know that one of my colleagues has established Wanda, which is sort of Afrocentric. You can go, I think it's wanda.org, and I'm not getting any money for saying any of these things. I don't, for any endorsements, but she's got a really terrific program that actually does have recipes that are more Afrocentric and incorporates the foods that people like, which, by the way, are a lot of very healthy foods. If we look at traditional foods from any country, like in Egypt is the example I use, given my heritage, the foods are very good. There's fava beans, sweet potatoes, black-eyed peas, falafel, they're very healthy. What happens though is that as countries become westernized or as fast food gets introduced for whatever reasons, then the quality of the food actually decreases. And it's interesting to me that peasant food becomes sort of the shishi food that's being served in the restaurants. But Ms. Jennifer, can you speak to foods that can be tailored to specific tastes?
Absolutely. So that's a really good question. And it's important to us as dietitians and also in the culinary medicine program. When I meet with a patient, one of the first things I do is really talk to them about what they eat. I spend a lot of time with them about what does a normal day look like? What does a special day look like? And not just what are they eating, but why are they eating those things? What is it about those foods and why they're eating it? Is it having to do with the time they have, or the skills they have, or the money they have, or their culture, or whatever the reasons are? And by finding out what it is and why it is, I could help them to figure out how to take what they're doing, sort of meet them where they are, and help them find ways that make sense to them to move towards their goals for better health. And we teach that, I do that in my practice, and I also teach it in culinary medicine so that the medical school students are also learning that technique.
I think, that, somebody like myself, I've struggled with my weight, and I know that when I'm sleepy, kind of overly tired like a kid, I may ingest more, calories, or I've had a hard day. I'm like, okay, what can I do to feel better? Or I don't have the time or the inclination. So can you speak to how sleep and lack thereof and food, how do those relate to each other?
Oh yeah. So starting with sleep, I mean, the benefits of sleep are very well documented. And for someone, for example, who's trying to lose weight, getting less than 7 hours of sleep is going to make it really, really hard to lose weight, because that's when your body does a lot of things that are required to help you lose weight. And so sleep is directly related to weight health. It's also related to stress, right? It's rejuvenating your body. So that is really important. And I'm sorry, what was the second part of your question?
If you're tired, do you consume more calories?
Yes. So that is a really good question. And as people go through their day, a few different things can happen. If they're on medications that sort of curb their appetite, and they're 12-hour medications, the medications can stop their effectiveness while you're still awake and you're up for 4 more hours. Also, sometimes when people are up and awake for longer, they end up eating more when they get tired at night, but also your metabolism changes. And so being up later is going to make it very difficult to lose weight. And so I've worked with some really great weight loss doctors at MFA, and they have really good advice. And it is, when you feel tired, go to bed. We all fight that urge. No, I want to do one more thing. No, I don't want to have to change. No, I don't want to have to go do whatever. But really, when you're tired, go to bed. Can help people go to bed earlier. I know it sounds simple, but
Yeah.
Yeah.
So here's a question from the chat. What is heart failure and what is atrial fibrillation, Dr. Lewis?
Okay, so two very different things. So heart failure is basically the inability of the heart to provide enough blood and nutrients to the body. And so patients with heart failure usually present with shortness of breath. They may have swelling in their legs. They may have fatigue. But any of those symptoms is definitely worth further investigation. Atrial fibrillation is an abnormal heart rhythm. So it's an irregular heart rhythm, and it's a very important one because it is one of the major causes of stroke. We have very good treatment for this, so it does not have to be associated with stroke. But untreated, it's uncomfortable. 2, it can lead to heart failure. But I think one of the biggest issues is that it's associated with stroke, and these strokes are often large and devastating.
So that's why we keep hearing all these commercials on TV
Oh,
for
yeah.
Eliquis or
Yes.
Pradaxa or what
Yes.
all the other ones. So
Yes.
it's really because as the population ages, then the electrical system, just like electrical system in our homes, you may need to rewire, and so there can be faulty signals that go to the heart to allow it to pump properly, and then you get a situation where the blood is kind of stagnant and then can form clot and then can break away and cause a stroke. So obviously these are distressing, and sometimes people will come in not having known that they had any of these problems. So is there a routine for people so that when they turn 50 or 60, you say, okay, you need to do X for your heart, or how does that work?
I think that having a good primary care physician is your starting point. And you should be in touch with your primary care physician. Let's say you're relatively healthy, at least once a year. And then she can determine what your risks are and where to go from there. A lot of people take a different approach. They think they should be going to all these different specialists. And, if you're a carpenter, everything is a hammer, right? So it's really, really important to have a good relationship with your primary care physician, and then let her try to help guide you into what kind of testing you should have from there. Because every single subspecialty has just numerous tests that can be done. And it's a question of what tests need to be done and what is going to help your overall health.
Well, we don't have enough general internists for sure. And you're right. Some of the worst care that I see is when patients go from this specialist to this specialist.
Yes.
I call primary care general internist. We're like the homeroom teacher that you always come back to kind of keep track. But I think one thing that we all underutilize in medicine is that the nutrition part is really underemphasized. So if somebody wants to get a consultation to see you, Ms. Leon, how do they go about doing that?
So there are different ways to see a dietitian. So for me at the Cancer Center, I work with the patients who are undergoing treatment at the Cancer Center. But there are dietitians throughout MFA. And so you would talk to your primary care physician and talk to that person, and she would help you be referred to the dietitian that is for that area of the MFA. And there are a few of us around, and we're happy to help.
So tell me, because I actually like the app Lose It. I use that to track my calories, and I find that it breaks down. Like I was looking at my protein intake and saturated fat and sugar. Do you, I mean, I'm not asking you to endorse one particular app, but do you think that those can be helpful?
Absolutely. We recommend often Lose It or MyFitnessPal, and there's a few others that are good. Really, anything that will help a person understand what they're taking in and how that fits with their goals is helpful. Even sometimes just writing down what people eat helps them just think about what they're doing before it goes in. But if you're really trying to understand, if you've been given some goals, let's say you're trying to have 2,000 milligrams of sodium a day, or trying to reduce your intake of saturated fat, and you're trying to figure out which foods have what, those apps can be really helpful, because when you put in what you had to eat, a lot of times the information is in their system and it tells you how much sodium is in that, how much saturated fat, were there any trans fats in there, and so on. And so it could be really helpful for people to gain an understanding as what's in the food that they're eating.
And I would just say, I mean, I have a weakness for barbecue or sour cream and onion potato chips. So I've stopped buying the big bags because I know it will happen. So I buy the small bags and keep them in my trunk, which is in the basement, right? I mean, I live in an apartment building. So no, but really it's worked very well, because then there's a limit. I'm just taking one bag and it's 160 calories and that's it, instead of just like, you're digging into the bag. There's a question that came through on the chat. How can I break the sugar habit? I feel
Yeah.
addicted to sugar. What can I do?
Yeah, I saw that one. I also saw the exercise one. So I just wanted to put it out
Sure.
there so we address it.
Sure.
So yeah, there is a lot out there about a sugar addiction, and I could tell you that there most of the time when I hear doctors talk about it, they don't think that's really a thing. But what the problem is, instead of calling it an addiction, right, we're just trying to reduce the amount of sugar that we take in for so many reasons, right? If you are taking in too many calories from sugar, it could add to weight gain or prevent weight loss. It could create an inflammatory response if you're overweight, if you're diabetic, and so on. So there's lots of reasons to want to reduce the amount of sugar that's going in. The recommendation is that people should have, should reduce their sugar in lots of different ways. And so the way that you could think about it is, are you drinking sugar? That's one way to think about it. Are you drinking Coke? Are you drinking iced tea? Are you taking things in just by drinking it? Are you getting, lots of grams of sugar? So that's one way to do it. The other way to do it is to look at the food you're eating and look at the ingredients label, right? If sugar in any form, so it could be, it could be straight up sugar or honey or agave or high fructose corn syrup. If that is in your label in the first, second, or third ingredient, there's a good amount of it in what you're eating. And if you're trying to eat something that you thought was healthy, but sugar came second, or even if you thought it was savory, like tomato sauce or bread, and you see sugar as one of the first few ingredients, you know that this is a high sugar product, and maybe look for one that has less sugar or no sugar added.
Mm-hmm. So I'd like to kind of switch gears now and talk about chronic diseases and how they impact the heart, specifically diabetes. We've talked about high blood pressure already, but diabetes is a big one, and even sleep apnea. Dr. Lewis, can you tell us about those two conditions?
Sure. So one of the things that I think is really important for people to recognize is that you have way more control than you think you do about your overall health. By controlling just the risk factors for cardiac and cardiovascular disease, we could probably negate 75% of the problems that we have.
Oh, wow, that much?
So, oh yeah. And so the big ones are the one that you mentioned, which is diabetes. And that's particularly important because as we look at the rate of obesity, right, in this country and actually globally, and that is of course related to diabetes, and that's kind of trickling down into much younger people. So as the rate of obesity increases, the rate of diabetes increases. And diabetes has it's not just about sugar, right? It has very important impact on the vasculature of the body. And coronary artery disease, for example, is much more common in diabetes. And I would mention, since I see most of the people on here are women, that when you look at probably two of the bigger risk factors, including smoking and diabetes, they actually have a bigger impact. They're a bigger risk for women actually than they are for men. They're not great for men either, but they're a bigger risk. I know that Jennifer may speak to this, but even modest weight loss. I mean, everybody doesn't have to be a toothpick. Even a modest amount of weight loss really reduces your risk of developing diabetes. Now, we have great treatment. You see it on TV all the time. But the goal is to prevent these things from happening. So diabetes, very strong risk factor for developing heart disease, among other things, vascular disease, and smoking. I think two of the largest things. Sleep apnea, there's a lot more data coming out about sleep apnea because of its relationship, for example, to high blood pressure is one issue, and intermittent episodes of decreased oxygen in your body, which can't be good. So we're seeing a relationship for sure with sleep apnea and cardiovascular disease, as well as high blood pressure.
And that's really why I think that the general the generalist perspective is so important, because when people come to a general internist, she or he should be asking, what's the quality of your sleep, right? Because that's going to have an impact. What's your diet? Where are you even carrying your weight? If it's a lot in your middle, that can increase not only diabetes risk, but cancer risk, right? Why are you eating a lot? We know that among certain populations, women specifically, who are very, very heavy, have a significantly increased risk, not risk, but a history rather, of having had sexual trauma. So if we don't recognize that and we're saying lose weight, lose weight, lose weight, that is not going to be helpful. We know that diabetes, poorly controlled diabetes is a significant risk factor for dementia, right? We know that sleep apnea is a risk factor for diabetes and weight gain and all these things. So I think that, as a homeroom teacher, I like to kind of bring it all together. But I think what you'll hear in sort of the themes, whether it's from Dr. Lewis or Ms. Leon, is that a diet that's good for diabetes or prevention, or for high blood pressure prevention, or cancer or heart disease, in general, it's pretty much the same. Is that correct?
Yeah, there are some general recommendations that run across all of the top diets to reduce risk for cardiovascular disease and for diabetes and for cancer. The Mediterranean diet is highly recommended for all of those. The DASH diet is particularly effective, especially for women with hypertension, but also is good at reducing risk for it. I compare the diets in detail, and they're the same recommendations pretty much, except for dairy, between DASH and Mediterranean diet. So if you're looking for a pattern to look for, those two work. Also, the American Institute for Cancer Research has something called the New American Plate. And that's just a way of looking at your plate and thinking, what components do I need on it and what do they need to look like? And that also is similar to the Mediterranean diet and the DASH diet. So those are three ways to start to think about it. I do want to answer the exercise question. Somebody is being good about reminding us about that. So the American Heart Association recommends that people get 30 minutes of moderate exercise every single day, or 45 minutes of vigorous exercise every other day to reduce risk for heart disease. And also those are the same recommendations to reduce risk for cancer.
Mm-hmm. But, I think sometimes people think, although nowadays nobody's going to the gym, but people feel like, well, the best kind of exercise is to go to the gym. And if you look at other parts of the world, I mean, walking is cheap, it's great. And then this idea that you have to do something in 30-minute blocks, you don't. 10 minutes here, 10 minutes there, and another 10 minutes is the same as doing it. And I'm very much in favor of apps. So for example, I was in clinic all day. And so a way for me to, and almost all the smartphones, if you have a smartphone, give you an idea. So I've not done very much, only 3,500 steps today. So that tells me, okay, I've got to move on either later today or tomorrow. Studies have shown that if you track what you're doing, you actually do better. But Dr. Lewis, are there recommendations for women over 60 in terms of exercise? Is there?
So the recommendations are largely the same. You need to be moving it every day. The only thing I would add for older women, no one breaks a hip for the most part just standing there. So as you get older, the balance is an issue, and tight muscles and joints are issues. So I think as you get older, a couple of things are important. One, warming up adequately, stretching after, and really being very proactive with doing things that improve your overall balance.
Mm-hmm. Yeah, that's definitely an issue. And the cornerstones of good health, that I think probably all of us were taught by our parents and grandparents, is that sleep is just such a core central, issue. And I think maybe the one silver lining of COVID is that people are not commuting as much and hopefully sleeping more, right? And then, of course, your nutrition is another sort of core pillar. exercise is another core pillar. And then finally, how, as you were saying, Dr. Lewis, how we respond to stress. Because first of all, not all stress is bad stress. Good stress helps motivate us to get projects done, to, do better, etc. So it is sort of those pillars. So I'm going to just, in closing, because I think we've got about 6 minutes left, this is your chance to talk about pet peeves or things that you wish that we knew. So I'll start with you, Ms. Leon. Are there common things that you see and it's like, you're like, oh, I have to explain this again?
Oh, well, a lot of the questions I answer most often are related to cancer. Does sugar feed cancer? And the answer is no, not directly, although sugar is not good for us. And so we don't want to have a lot of it. But that is the question I get asked the most every day. I do also, I get asked a lot of questions about alcohol, which we have covered. Yeah, I think those are the two most.
Oops, I think we just lost her.
Oh,
All right. Dr. Lewis, your turn. Anything that you wish people knew or that you hear often that may be myths or misconceptions?
yeah. Here's the thing. Maybe this is a slightly different answer to what you're asking, but one of the things that I try to instill, we deal with a lot of trainees, and this I hate for a presentation to start with poor historian. I hate that. So as a patient, it is your right to understand your issue. That is your right. Now, you may not understand all the terminology, but your care, the care of your body, of your heart, is in your hands and your doctor's hands, right? So it's really important for you to be informed and to insist on being informed. So I think that would be one of my
Yeah. And I would add this, especially, and I know I see your back. I saw that you were in the snow at one point with that virtual background, but
Sorry about that.
yeah, one of the things that I always recommend when you are going and you're expecting a tough diagnosis, or you've been told that, look, you've got cancer, you've got heart disease, the next time or any time, feel free to bring a loved one, because what the studies have shown, remember that Charlie Brown cartoon where the teacher would be like, oh, wow, 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 wow. We don't hear because one is so emotionally sort of overwhelmed or flooded that you can't hear. So I think that people can feel free to bring in folks. I encourage people to ask questions, and because you really do have to understand the reasons that you're, the Dr. Lewis or Miss Leon are recommending certain things. So you got cut off in mid-sentence. Do you want to come back and tell us, you said sugar doesn't feed cancer?
Yes, sugar doesn't feed cancer, but it's not that good for us. So it's okay to, and recommended to reduce it. But I would hate for my patients, there's a lot of misunderstanding about that. So I explain that an awful lot. And I talk a lot about exercise. A lot of people have a lot of questions about exercise. And so I like to explain that. And then also, what are whole grains? And I know these are kind of big topics, but I often explain that when people are trying to understand what is a whole grain and how do I incorporate that, I answer a lot of questions about that. And basically, I can give you the real quick answer is that if you want to know if something is a whole grain, you look at the ingredients list and the first word on it would be whole. So whole wheat, whole rye, whole barley, whole whatever. And that's how you know that you're choosing a whole grain. That's what you're looking for.
So thank you. In our last 2 minutes, Dr. Lewis, COVID and the heart, is there a relationship there? Can COVID affect the heart?
Yes. So when we initially saw a lot of COVID patients were presenting with what looked like heart attacks. And there also, of course, it's a virus which can attack the heart muscle. So yes, it can affect the heart, and very seriously so.
Mm-hmm. So I know that we have a long haulers clinic where people can get seen in a multidisciplinary fashion, which is important to kind of track the symptoms. Well, ladies, it's been delightful. We appreciate your spending this hour with us. Dr. Lewis, cardiologist, and also the head of the Women's Heart Program at GW, and Ms. Leon, who is not only a registered dietitian in the Cancer Center, but also is a clinical instructor at the medical school and teaches students about culinary medicine. Thank you both so much for joining us. There were so many great questions that came through the chat, which tells me that you are very engaging. So thank you. And for us, from the Rodham Institute, please visit our website to find out more. If you missed part of this presentation, or you have a friend that you want to see it, you can just watch it again, because we have an archive of all of our previous webinars. So have a good night, everybody, and take care. Be safe. Vaccines are on the way, and please take care. All right.
Thank you for
Thank
having
you
me.
so much. Thank you.
Thank you.
Bye-bye.
Good night. Bye-bye.